those within no prophylaxis compared to 1.8 in low molecular weight hepatitis. This is almost more than 50% reduction in the incidence rate.
Yeah.
And this is a graph showing the incidence of pharmacology. In the post-operative period, you can see that in those with reduced the incidence was higher in post-operative period and later on also. And those with low molecular weight hepatitis, the incidence is substantially lower. So I would like to emphasize on the importance of following the guidelines that the American College of Distribution evidence-based clinical practice guidelines. And for patient undergoing hip fracture surgery, ACCP recommends use of one of the following anti-thrombotic prophylaxis, that is low molecular weight heparin or fondaparinux or low dose adjusted heparin or adjusted dose vitamin K antagonist or aspirin or an intermittent pneumatic compression device rather than no anti-thrombotic prophylaxis. That should be for a minimum period of 10 to 14 days. And they recommend using low molecular weight heparin over all the others because of the risk of bleeding with other agents or lack of efficacy of the other agents. And they recommend starting it either 12 or more hours pre-operatively or within 12 hours after 12 hours post-operatively rather than within 4 hours. And for patients in outpatient, they recommend to continue it up to 35 days from the day of surgery rather than for only 14 days. And those who are admitted, they recommend a dual prophylaxis with an antithrombotic agent along with an intermittent pneumatic compression device. In patient undergoing major orthopedic surgeries who are non-compliant with their drug regimen, with an intermittent pneumatic compression device, oral agents can be used like apixaban or dabigatran. If they are unavailable, then adjusted dose vitamin K antagonist or dabigatran or rivaroxaban can be used. And they strongly recommend adults using a inhibitor vinegar filter treatment for primary prevention over no thrombophlebitis. In patients with increased bleeding risk or those with contraindication for any pharmacological or mechanical thrombophlebitis. This is also very important for patients following major orthopedic surgery. They recommend against Doppler screening before hospital discharge because it has not shown of any value. And on Doppler scanning, if they found to have some thrombus and if the patient is started on anticoagulation, that was found to have more risk of bleeding and adverse events. So they strongly recommend against use of these two, against Doppler screening and inferior vena cava filters in asymptomatic patients. So to conclude, I would emphasize on the importance of following the guidelines for managing patient undergoing major orthopedic surgery in the perioperative period.
Very simple, just follow the guidelines.
And guidelines are very clear.
They are very clear, so you don't have to question them. This is what we should do all the time. Thank you.
The topic of minor presence of cerebral venous sinus thrombosis. Cerebral venous thrombosis is an important cause of stroke in children and young adults. Often the clinical features are non-specific, so the diagnosis depends upon the imaging. Late diagnosis leads to severe morbidity and mortality, so an early diagnosis by AMAANA is essential. So coming from case study, we have 3-year-old child who presented with the pediatric clinic, and she was placed in the MR examination. The MR was performed on a 1.3 Tesla magnet using a head coil. Initially, we performed T2 with the fan methods. On both T2 and fan methods, you can see that in the right basic similar mechanisms as for the internal capsule and mid-right. This signifies some sort of lesion. So next we did the diffusion method imaging. On DVR of 1000, we got a hypersensitivity. This signal turned dark on AD synapse, suggesting this signal. So next, the same area was observed on T1 images, which knowledge appears in light. Anything which is bright on T1 is usually fat or hemorrhage. So we did a GRE to confirm the next observation. On GRE images, the same area showed moving. So this was confirmed to be hemorrhage. And normally, a superior surgical sense was appears as a slow one. That is equal to a dog signal on T2 images. However, in our case, we got intensity intuitive. And the same superior sense was bright on T1 and it showed moving on GRE images. This was suggestive of a thrombosis. Then we did a post-contrast scan to confirm the thrombosis. On post-contrast scan, the entire thrombus within the sinus is visualized. And another thrombus was detected in the renal channel. On retrospectively looking, we can see that there is another hyperintensity and T1 visual images in the venous region. So to an infarct in the right basal ganglia and internal capsule, which is hemorrhagic with filling defect in the space sagittal sinus and in the vein of suggestion of thrombosis. So, cerebral venous thrombosis is often uncommon, so it's not suspected. Usually, when we get an infarct, we usually think of an arterial thrombosis. So, these are the things when we must think of a venous thrombosis. That is, when we see a direct sign of thrombosis, either on CT or NET. The dense clot sign means you get a hyperdensity on CT, or it's either hyperdense on T2 weighted images, or the center of the sinus remains unclassified. And in the case of cerebral venous thrombosis, the thrombosed vein can appear as a cord. This can be easily seen on CRD or T1 weighted images. And last, this is the most important sign. When there is a loss of normal flow void on any of the sinus phenomena, you must suspect the thrombosis. When the infarct, coming to the venous infarction, we must suspect the infarct is venous when it does not involve typical large arterial artery, when it's bilateral, when it's located near the midline, and venous infarcts are most commonly seen in the temporal lobe region. And when it's associated with a hemorrhage, it's most probably a venous infarct.
Thank you. We haven't seen much of MRI diagnose venous thrombosis. Thank you.
This exposing spectrum and thrombophilia, advanced age, chronic heart failure and obesity, immobility and paralysis, and myeloproliferative disorder, pregnancy, postpartum disorder periods, and estrogen therapies. This intersectoral area including cancer and inflammatory bowel disease. And here this exposing and predisposing factor, because we cannot conclude this prevalence of this VT because it's not a community-based study. It's only hospital-based study or ICU-based or that. And in the prevalence, we should take the whole community, whole population. That's why we have no any idea about the prevalence of this venous thromboembolism. So I want to show this exposing and predisposing factor of this VT. And after this exposing and predisposing factor, I want to show this virtual triad. It includes endothelial damage and hypercoagulability and stasis. Endothelial damage, endothelial dysfunction. It includes most common cause of endothelial dysfunction is smoking and hypertension. And endothelial damage is because of surgery and catheter, like PIC catheterization and trauma. Hypercoagulability, it may be hereditary or acquired, and hereditary factor is Leiden or prothrombin and protein C as deficiency, and acquired is cancer, chemotherapy on HRT, and pregnancy, obesity, and HIV. This is stasis, there is immobility and polycythemia and all this. I am very brief and very short to explain this.
This is an important topic because many times we say.
But your lecture is very informative there because tenecti plays and LT plays and that GABA, that PD inhibitor, that GABA Devi Garden. It's very yes.
All the surgeons who are dealing with medical ops because they cannot capture data. So at least you will know how much is going to. It's less than in Western countries, but how much is it in the hospital? You don't know exactly. So yeah, I mean, the community guys and research is always important.
Thanks.
So, venous thromboembolic phenomenon is a well studied condition in the Western world. But in India, still the study lags much in the epidemiological and demographic study. It lags a lot.
That's what I was saying.
Yes, exactly. That's and that is our effort in this particular patient. And it was a prospective observational study over a period of 7 months. And we included 622 patients, of which 26 were diagnosed and were included in this particular study. So in these patients, we divided into group 1 and group 2. So group 1, we included deep venous thrombosis and pulmonary thromboembolic patient. In group 2, we included cortical venous thrombosis, patient with cortical venous thrombosis. So in the prevalence, we found that 4.18% was the prevalence in our particular study. And of that 36 patients, in group 1 patient, we had 19 number of patients. In group 2, we had 7 number of patients. The age group, the overall age group was 40.7, sir. In group 1, it was 43.42. And in group 2, sir, it was 1 decade lesser, that is 33.29, sir. In gender distribution, we found that group 1 was represented more by the male, whereas in group 2, it was the female population which was the predominant population. In the symptoms, sir, the most common symptoms in group 1 were breathlessness and swelling of feet. And apart from that, other symptoms were distended abdomen, fever, chest pain, cough, orthopnea, pain in legs, hemoptysis and palpitation. And in group 2, the most common symptoms were headache and limb weakness. And other symptoms were abnormal mental functions, vomiting, blood vessel, and seizures. So in 80% of the patients, we found associated risk factor. So in group 1, we found that in 5 of the patients, we could not exactly associate them with any of the risk factors, but the other associated factor which we could associate with thromboembolic phenomenon, smoking, alcoholism, nephrotic syndrome, ischemic heart disease, earlier condition of pulmonary embolism, malignancy, immobilization, and oral contraceptives. And in group 2, sir, the most common associated risk factor was with puerperium, esophageal carcinoma, CSM, and in one case we could not determine any of the any risk factors. All of the patients were subjected to radiological examinations. So in deep venous thrombosis, we found that the duplex ultrasonography was very sensitive and specific for that particular condition. And in pulmonary embolism, we found that CT, pulmonary angiography, was the investigation which helped us in clinching the diagnosis.
Density was 90+%.
7 out of 8 patients.
Yes, sir.
It was very good.
And in cortical venous thrombosis, we found that it was AMAANA and venography which was the investigation which was very sensitive. And so it had a very high sensitivity specifically. Apart from that, we backed up the diagnosis with specific laboratory investigations to find out the specific risk factor which were
Thrombophilic state basically.
thrombophilia, which had
was
associated thromophilia. So we did phospholipid antibody, then anti-nuclear antibody, D-dimer, apolipoprotein, hyperhomocysteine, hypertriglyceridemia, protein C and S, antithrombin, and even factor V variants.
The good thing was that of the total number of patients, we found some thrombophilic state in at least 30% of the
30%
patients.
patient we found thrombophilia. And after the diagnosis was made, most of the patient they were given low molecular weight heparin. And in 5 of the cases, they underwent thrombolysis. We also gave them antiplatelet agents. The outcome was
It's a long-term condition. So since the mortality is 27% is a little higher,
associated with quite high.
early diagnosis and treatment is important.
That's why it's important.
Yes, sir, that's why.
That's why we are talking about it.
Exactly.
We don't get so much emphasis on this disease.
Yes, sir. Yes, sir.
But clinically,
The symptoms and risk factors all given in the textbooks, but because we are not undergoing investigations which you know and not easily available in India, so they tend to be more underdiagnosed conditions.
Even when you see a patient, you don't think about it. You just stop
Yes. Even the symptoms, there are vague symptoms like headache maybe, or some little bit of breathlessness, which is not very uncommon.
The only limitation of the study was that the subjects were less. Means 26 cases positive, but we
just to start everything, demography.
wanted to see conservative in this study.
Thank you very much. Thank you so much.
I take pleasure in presenting you the last poster of PET, hopefully, which again impresses one particular fact that most of the posters here said that imaging features in cerebral venous thrombosis ultimately helps you to place the diagnosis of a condition which is not specified. So, going forward with the introduction, venous thrombosis, cerebral venous thrombosis, especially refers to occlusion of venous channels in the cranial cavity. It could include any of the veins, the dural venous thrombosis it could be, or it could be a thrombosis of the cortical veins or even the deep cerebral veins. Illustrating, sorry about the picture here, illustrating the veins of the these are the structures of the brain. These illustrate large venous sinuses. The veins more towards the center, these illustrate the deep cerebral veins. And going deep into the brain tissue, these illustrate the cortical veins. And thrombosis of these structures usually coexist. An isolated form of thrombosis is not a usual occurrence. So this is the illustration, and this is an MR venographic picture of the cerebral venous system. Illustrates the same, but I'm sorry about the picture. It illustrates the percentages of the incidence of thrombus in each of these venous systems. For example, in the superior sagittal sinus, which is the most commonly affected system, the incidence of thrombosis is around 62% among all patients who come up with thrombosis. And that in transverse sinus is about 40%. The cortical veins and the remaining transverse sinuses in all these veins is about 15 to 20%, and the remaining are much less. Coming to predisposing factors, what a clinician or a radiologist should think before we go on to evaluate the patient. We definitely think about what happens with basically cerebral venous thrombosis, as you know, is a condition which happens most often in young patients. Like the previous poster said, it affects people when they are economically most productive. So in young patient, a young patient who comes with altered, they can either come with non-focal neurological symptom, or they can come with focal neurological symptoms like stroke, like weakness or paralysis. So if a patient comes with this presentation, the first thing we're going to think about is echoparadigmal states in the patient, like the antithrombin factor deficiencies, and we are also going to think about hemoconcentration in the form of dehydration. And coming to particularly for cerebral venous thrombosis, we could think about local infection, especially in the case of acute mastocytosis, when the infection can spread into the lateral sinus as lateral sinus thrombophlebitis and probably spread further. Particularly in women, even though the previous set of risk factors hold good for them, there is a specific risk factors for them, which includes oral contraceptives and particularly the peripartum period, which I would like to impress upon, because the peripartum period again is a hemoconcentrative state, a pro-thrombotic state, and added on with the additional risk factors of surgery, of infection and blood loss during surgery, the patient is at risk of surgery, venous thrombosis or venous thromboembolism in overall for that. In children, again, acute systemic illness and hemoconcentrative states like shock and dehydration and local infection, again, acute mastocytosis plays a very important part in children. The clinical complaints are often non-specific, and imaging features are very subtle. This is what the radiologist has to pick up, and misdiagnosis can lead to severe consequences, especially hemorrhagic infarction, and it can ultimately lead to death. And also long-term neurological sequelae, which again form a significant morbidity in these people. Early and correct diagnosis relies on neurological imaging, and in providing this, we as radiologists take pride in providing the crucial turning point for a diagnosis and thus help in patient care. Citing the case of a young lady, we outline the utility of magnetic resonance imaging in diagnosing CVT. The patient was a 28-year-old female patient who presented to the emergency department with complaints of irrelevant speech and seizures. What was important was the onset of symptoms was 2 days following a full-term normal vaginal delivery. And there was no significant past history of medical illness to suggest anything. And on examination, the patient was on sensorium, but there was normal movement of all 4 limbs, which suggested that probably there was no focal neurological involvement. And examination of the other organ systems were within normal limits. Neurological imaging was sought after in this really confusing situation, and the patient underwent MR imaging. In MR imaging, she underwent sequences T1, T2. She underwent flare sequences, diffusion weighted and susceptibility weighted images, and finally we also performed a phase contrast MR venogram sequence, which is and you can see over here. These are subtle cord-like hyperintensities, and we thought these could probably represent a cortical venous thrombosis. So we went ahead with diffusion restriction sequences, which showed there was diffusion restriction within these lesions, and the ADC map again corresponded with subtle hypodensities there. So we went ahead with the impression that these